Hello and welcome to this special Reuters interview series looking at the impact of misinformation on our communities. This interview is independently produced by the Reuters editorial team. Before we begin, we will first hear from Facebook, the sponsors of this series.
Hello, my name is Siobhan Comiskey. I lead Facebook's campaigns and programs team in EMEA. Over the past year, I've been particularly focused on our efforts to support governments and public institutions addressing COVID-19, which, as we know, has had a profound impact on millions of lives. So what have we done so far? We've taken meaningful steps to limit the spread of misinformation about COVID. Since the start of the pandemic, we've removed 16 million pieces of misinformation about COVID-19 from Facebook and Instagram. And we've also added warning labels to 167 million pieces of content. We partner with over 80 independent third-party fact-checkers covering more than 60 languages to fact-check content on our platforms. We launched the COVID-19 Information Centre to help people find credible health-related news, government advice and statistics all in one place. So far, more than 2 billion people have used it. We've also committed $120 million in ad coupons to help health ministries, NGOs and United Nations agencies reach billions of people with authoritative health information. In Europe, Middle East and Africa, we ran a media literacy ad campaign to help people spot health misinformation and provided advice on what to watch out for. Now that many countries are moving forward with their vaccination programs, we've launched the largest worldwide campaign to connect people to authoritative information about COVID-19 vaccines. We've heard from health experts that it's absolutely critical to help build vaccine confidence around the world. That is why we're particularly pleased to support today's conversation, to create greater awareness about vaccine hesitancy and help to make sure that people have access to credible information about vaccines.
Thank you for watching. I'm Hazel Baker, I'm a Reuters journalist and I'm the editor of our social media fact-checking unit. With the COVID vaccine rollout now well underway here in the UK, many are hopeful that the end of pandemic restrictions is near. The latest data shows that over a quarter of Brits are now fully vaccinated and the number is rising daily. But these figures don't tell us the complete story. Recent research has highlighted disparities in vaccine uptake, particularly when broken down by ethnic group. In this interview, we'll consider some of the factors driving this disparity and ask how they might be addressed. I'm very pleased to welcome two guests today. Dr. Winston Morgan is a reader in toxicology and clinical biochemistry and also Director of Impact and Innovation in the School of Health, Sport and Bioscience at the University of East London. An active research scientist, he has written extensively on the impact of COVID-19 and uptake of vaccines in relation to race and ethnicity during the pandemic. I'm also joined by Kelly Rostron, who is Family Service Coordinator at Mary Seacole House in Liverpool. Mary Seacole House is a mental health charity that gives support and advice to the local community, but primarily for those from a Black, Asian, minority ethnic or refugee background. Since the start of the pandemic, Kelly's work has taken on a new dimension as she helps connect local families with accurate information about COVID-19 and vaccines. Welcome to you both and thanks so much for being here for this discussion. I thought we could start with some new research. The UK's Office for National Statistics, the ONS, recently reported that more than 9 in 10 British adults surveyed expressed a positive sentiment towards the vaccine. However, research also published last week by the ONS showed that rates of first dose vaccination in over 50s were lower in all ethnic minority groups compared with their white British counterparts. The lowest rates were recorded in those who identify as Black Caribbean and Black African. These groups had 67% and 71% vaccination rates respectively. That compares to 94% among the group identifying as white British. Ethnic background was not the only factor linked with vaccination rates. Language, religion and socio-economic background also appeared to be significant. Dr. Winston Morgan, perhaps I could start with you. Do these research findings come as a surprise to you at all?
No, good afternoon. No, the findings don't come as a surprise to me, primarily because if you look at the pattern of the uptake of the vaccine, they're very similar to what happened around deaths to COVID, for example, the same groups of people were disproportionately affected. And nothing structurally has changed in terms of what we're doing and how society is organized. So it's not surprising that just as people were more likely to die from these groups, from the virus, they because of perhaps they didn't have access to the right kind of support and help. Similarly, those systems are not in place to enable them to get the vaccines. That's just one example. The other thing, vaccines are really difficult thing for everyone, not just those communities that you've described, simply because they're, if you like, they're related to the pathogen that you give to people by injection, and you have to give it to people when they're healthy. So all of these things means people naturally don't want to take a vaccine. And so what you need are clear messaging from governments and scientists to say this is safe. And that messaging has to be delivered by what we call trusted messengers, people who the community will believe and then follow them. And what we found is that a lot of these, for some communities at least, the messaging hasn't come from these trusted messengers. It's come from central government, senior members of the NHS and that kind of thing, but not from local people who they know and trust. And so they haven't been able to take up the vaccine at the rate they probably would.
Right, we've seen the government try to reach groups with campaigns, either centralised campaigns from the NHS, etc., or independently organised by members of the community. Do you feel that those broader campaigns which are trying to address a whole community and the whole country are perhaps too broad? Is localised messaging more effective?
Well, there's nothing wrong with doing them, and they may have had some success. But first of all, they came a bit late. Very early on in the pandemic, even before the vaccines were approved, people were contacting me and saying, I'm not keen on taking this. At the time, they saw it as an experimental and new and untested vaccine. They didn't want to take it. And what we needed at the time were clear messaging from the government saying, first of all, it's been properly tested in different groups of people, and it isn't, you're not going to be the ones who are taking it first and the only ones in it. So that reassurance didn't come. And by the time the reassurance came, people had already started listening to, if you like, other voices who were suggesting they shouldn't take it. So it's all about timing and also about clear messaging. The other thing is, early on again in the pandemic, the virus was allowed to become what I call racialized. That means it was linked. So if you were it was thought that if you were from a certain ethnic group or racial group, you were more likely to suffer from the vaccine. And rather than accept that this was due to social factors, it was suggested that it might, or it wasn't said, but the implication was that could it be something genetic linked to these groups? And because things like that weren't stamped on, the moment you racialize a virus, you racialize the treatment for the virus, because people are going to think, right, if the virus is affecting us more, could the vaccine also affect us more? So all of these things needed to be taken into hand when people were talking about giving people vaccines. You really had to sort of address these questions, and they were never addressed by, as I said, trusted messengers in a very specific and localized way. If you look at the progress that's been made early on, the Bangladeshi community, for example, they weren't taking up the vaccine, but then what people got to do is to actually talk to leaders in those communities and have really focused, localized campaigns. And you can see the difference if you look at the data. Bangladeshi community now, one of the communities that are really taking up the vaccine in a much more, in a similar way to the white community. So you really have to be very targeted in what you do. And that campaign has been successful. Theoretically, it's possible to get a similar campaign for other communities, but it's going to be much harder as time goes on.
Right, and presumably you need to understand what's driving the fear or the reluctance to begin with. Do you think adequate listening is being done to these communities? And do you have any idea of some of the main fears or anxieties which they're expressing?
Well, the thing about anti-vaxxers, who are the drivers of this fear, they'll basically pivot as soon as they'll put a message about, it could be fertility, for example, and then the scientists and the fact checkers say, give the real information, and they'll move on to something else. So it's really, they're pivoting all the time. And what you need, as I said, is trusted messengers to sort of go into those communities or talk to those people and give them the information and then come back. Not just say it once and then go away, not just have a video with celebrities or politicians saying, yeah, I took the vaccine and my mother took the vaccine. You actually have to, sit in front of people and listen. When they ask you questions, answer those questions. And if they go away and come back again and they're still uncertain, they'll ask you those questions again and you answer those questions. And that has to be done locally, not distant campaigns, as I said, from people who are famous or celebrities.
Right. And do you think there is a kind of general lack of trust in what's being messaged by big health leaders, etc., by health authorities, both in the UK and wider? Is there a lack of trust that we could address that could be something that would help increase confidence in vaccines amongst these groups?
Well, it's a historical thing because, as I said, the engagement with the NHS generally, or health service generally, by these communities is not as great as as for the white community, and so you're starting off from a big disadvantage. So you then need to work twice as hard to get those communities to engage, and to sometimes they're just off. They don't have a relationship, for example, with their GPs, because normally you might get an email from your GP to say, come in and see me, or it's your turn to take the vaccine. If you're not engaging with your GP and your health workers and that kind of thing, it's not going to happen. And I said that's a historical thing. It didn't start with the COVID-19 pandemic. It's been going on for some time. And so assuming that things are going to work perfectly because there's this large campaign was always a mistake. You really had to sort of look deeply and say what's been wrong over these years and do something about it. And that hasn't really happened. Even now, if you look at the race disparity report that just came out recently, there's been for the health part, there's been a big push to try and say there are no health disparities and health inequalities generally, but when you look at the data, there clearly is. And it's that kind of messaging which confuses people.
Understandable. And as a fact checker working with misinformation throughout the last 12 months, we've seen no end of misinformation around the vaccine. We have also seen examples which specifically target certain racial groups. They drive fears, they encourage people to doubt the vaccine. How much of a role do you think such misinformation, particularly targeted misinformation, might be having on overall vaccine acceptance rates?
I think, well, as I said, it depends on the community. It will have a big impact. As I said, if you initially had a poor relationship with the NHS, and as I said, vaccines are one of those medications or medicines that people generally are apprehensive about. All you need is a slight push in that direction, and you won't, and you're not going to take it. And that's what's happening. It doesn't take much for vaccine, especially if you don't, as I said, you're not confident in what the government is saying, and there are people on the other side saying something else. And we can talk about the sort of historical thing, and people exploit that to sort of to make sure that people don't take the vaccine.
Certainly we've seen reference to previous medical experimentation, etc., which is being used to drive this narrative. Thanks very much. At this point, I'll bring in Kelly Rostron, who has definitely been working and heard some of these concerns expressed firsthand. Kelly, could you give us a little introduction into your work? Because your organisation delivers mental health support. So how did it come to be that you were working on delivering vaccine information to the communities that you work with? Okay, sorry, we seem to have a bit of a difficulty hearing Kelly, so hopefully we'll come back to Kelly soon. Winston, in the meantime, the question I really wanted to kind of ask you was, can we learn anything from this disparity? Is it too late to sort it out now? Can parity be reached in the timescale that we've got, looking at this pandemic, or is it something that would need to be addressed over a much longer period?
Well, as I said, you can, by doing local, really focused campaign, you can make progress, but it's not going to be great. And if you look at the data, what you're seeing, we're now moving towards the younger age groups below 50s, and it's not just the black and other minority groups who are more reluctant as you get younger. It's happening to the whole population simply because they feel less threatened by the vaccine and by the virus. So it is really going to be hard, but I still think it can be done with more focused campaign, but it requires, as I said, a lot of work, a lot of hard work, a lot of people on the ground who the community trusts, these trusted messengers that I keep talking about. So I am optimistic. I don't think we'll ever close the gap. So you'll get sort of like, especially over this short period, simply sometimes the structures aren't there in local authorities or local areas to actually find and encourage people to come in and take the vaccine. So there are those factors that we haven't actually even begun to talk about, the structural inequalities that even when people hear about the vaccine, they don't, they just can't get to it for whatever reason.
Right, so that's a practical issue rather than an ideological one.
Yeah,
at this point, great, thanks. At this point, I think we've got Kelly back. Kelly, can you hear me now?
Yeah.
Fantastic. So, as Winston was mentioning, trusted messengers is key to much of this kind of reaching those communities and helping people get the information that they need. Kelly, you actually work with a mental health organisation. So how did it come to be that you've been working on the COVID-19 pandemic and providing information around vaccines?
Well, Mary Seacole House, we're based in Toxteth in Liverpool. We're a multicultural mental health resource service primarily for the BAME community. But under our umbrella, we've got a few different services. We've got the mental health day service, we've got the advocacy, and I run the family support service. So what we've always done within the family support service and the day service, we've looked at, we looked at the service users holistically, not just dealing with just the mental health. Because a lot of the people that come to our service, they've got a lot of other health inequalities. They've got high blood pressure, they've got heart disease, they've got high cholesterol. So these are things that we've always addressed. So obviously COVID was something else that needed to be addressed. Because we've got a good standing, like I said, we've been there 30 years, a lot of people within the community listen to us. We understand the cultural issues, we understand the health inequalities that they face for generations. And we wanted to ensure that this wasn't going to be another thing that, drawn a line between them, that people were not addressing the COVID, because there was an awful lot of anxiety about things. So that's why we decided to focus on making sure that people understood the COVID. A lot of the information wasn't available in their languages. Right. So we've had translators, and that's why I thought it was important that it was spread across the board.
Certainly, and for anyone watching who doesn't know, Liverpool was actually one of the cities in the UK that was worst hit in the autumn and the early winter by severe COVID spikes. Presumably there was quite a high degree of anxiety amongst the groups that you work with. Did you feel that they were able to access the information once, if you made translations available? Did they still have questions? Did you sense a lot of fear amongst those communities?
There was a lot of fear, and especially a lot of the information on the news and in the headlines. Strangely enough, we found a lot of people didn't actually understand that they were classed as BAME or BME. They didn't understand the information that was being given specifically for the groups that we work with. Princess Ward was highly hit. We worked really close with public health, and we were out. Public health were out in Liverpool, knocking on doors, physically active. It wasn't just putting leaflets out. It was door knocking. It was attending them, everywhere and anywhere, going to the local shops, giving the information out in formats that they could understand. We've got a lot of the older Arabic community who can't read Arabic. They can't read English. So putting leaflets out in their language doesn't benefit them either. They needed a face to explain to them.
And are these things that you knew prior to the pandemic? Did you know that there was a kind of gap in messaging for these groups?
Yeah, there's always been a gap in service provision. The provision's there, but a lot of people don't understand how to access the services. A lot of information is available in certain languages. There's so many different languages nowadays, you can't cover all of them. But I think a lot of people forget that a lot of people can't read their own language. It doesn't. So you need to actually explain face to face. We've done a lot of videos. We've had faces that they recognised from the community doing the talks in their language.
Right. And when it came to the vaccine communication, which is potentially even more complex in trying to explain the COVID pandemic, because many of these use new technologies, did you sense that the gap widened even further? What kind of anxieties were expressed by the people that you worked with?
there was a huge sense of anxiety about the vaccine. There was a lot of misinformation being passed through social media within the community, fake news, and it was, trying to gather that information and, put the truth behind the information. We were getting told that, people thought there was going to be fertility problems, that it wasn't haram, it was forbidden against their religion, that COVID didn't exist, that they were going to be microchipped. So, we were fortunate enough, we had a GP, Dr. Laura Stirrat, who joined some sessions with us. So we had question and answers. So, and we told all of the service users, just ask. No matter if you think it's a strange question, we'd much rather dispel any of the myths that you've got and, give you the facts. So just ask the questions. And some of the questions, you might think were strange, or like being microchipped and that they were being tested as guinea pigs and things. But, the fact that, we were able to talk to them in their own language. There was other people in the groups that could ask the questions as well. And the GP could answer the questions in a way that they could understand.
And did you find there was good feedback after those sessions? Did people feel that they had been listened to and got the information that they were looking for?
Yeah, the feedback was really, really good. A lot of them, and especially like with the day service as well, there was a lot of people on medication. So they were worried about having medication and it being affected by getting the COVID vaccine. A lot of them have said that they felt that they were finally getting listened to. They could ask the questions they wanted to. We used a different way of working with them. I think we've been pushing the vaccine, obviously, because a lot of people, just didn't want the vaccine. So we've been promoting it as well. So we've been asking them when they get the vaccine, send us a photograph. We put it on this little wall of fame. We've been asking them to send videos so other people can see, it's people, again, that they know have had the vaccine. And then they were able to ask each other questions, how did you feel after your vaccine? Were you ill? Some of them were saying, it was easy, it didn't hurt, I didn't feel it. I wasn't well for a few days. But it was people that they trusted to get the information from. Like I said, not just like something that they'd seen on the news or a post to say, So I think it's important to have people from the community to talk. I think COVID has highlighted more health inequalities. It showed you the gap that we've been saying for a long time, that there's all these health inequalities. But I think with COVID, I think it's highlighted it, and also it showed the importance of having voluntary and community grassroots services working with the community. We understand the community we work with. We've got service users, we've got staff that live in the community. It's not just somebody high up or in the news telling you what they think should be happening, what is happening in the community. We've relied a lot on peer support. We've relied a lot on people within the community. Service users giving their own information. It's more trusted.
Mm-hmm. So those connections already exist within the community. It's just making most of them and making sure that they're used as a way to transmit information. Winston, this is exactly what you alluded to before we came to Kelly. Does it scale up though? I mean, all the initiatives that Kelly's project has been carrying out sound really beneficial to the communities that they serve. Is it possible to do this at scale across the UK and beyond?
Well, I think it is. I work closely with Newham Public Health, and that's exactly the kind of thing we do. They have COVID champions, who are people who different community groups know and trust, and they will go into those communities and talk to them about the questions they will have. And I said we do these every 2 weeks, especially early on when the vaccination process started. People could come on a Zoom call and talk to us. We'd have scientists, GPs, other people, and it's the fact that you didn't go away. Every 2 weeks you were there, so they can come back with new questions, and that was really, really important. So it can be scaled up, but it does require a lot of work from the sort of like the equivalent of the public health department within a local authority. They really have to put the work in so that would mean more government support.
Right, and do you see initiatives like the Mary Seacole House projects being carried out in other places? Have you heard about similar projects being run?
Well, as I said, I suspect there are pockets of these, but they're just not enough. If you take one of the problems with the Afro-Caribbean community, the Caribbean community in particular, is they're more dispersed, I think, and so it's harder to get one sort of session that would deal with all of them. I do a lot of them where I go into various Caribbean societies and talk to people about, and they ask me questions about vaccine safety or whatever, and I can talk to them. But most people are quite dispersed; they're not concentrated in one area, and so that's another challenge that we have to face.
Right, and if our health leaders and politicians were to learn anything from the rollout of the vaccine and achieving parity, is there anything in particular that you would like to see as being a main takeaway?
Well, clearly trust is really important, and what the government did, and it's really impressive. They had, very sort of like some very charismatic doctors like Professor Van Tam to talk to people, and that worked for the general population to reinforce that trust. So that kind of thing was really good. But as I said, but you have to do it really early on. If you allow the anti-vaxxers and those people who send negative message to come in, then it's really hard to counter them once they start. So you have to jump onto something like this really quickly and bring in all the community, not just the general, not just those who are already engaged, but those who are not normally engaged. And with something like an infectious disease like a virus, you can't leave anyone behind, because then you can then get variants forming in those communities and that kind of thing. So it's really important that you bring everyone in very early on and you reassure them.
And do you think that includes addressing some of these seemingly quite wild theories about the vaccine? The questions that Kelly mentioned that she'd heard from people in the groups, and actually we've seen plenty of examples of these from all groups on social media around the idea of microchipping, infertility fears. Do you think that we need to address those more robustly at the start rather than waiting for them to gain traction?
Yeah, but I think even before you get to specific examples, the reason, as I said, why I know, for example, in the black community that, some of the black communities, why those stories got traction is because people didn't believe the early messaging in the first place. And then once people don't believe the messaging, they're looking for excuses. They sort of look to what could it be? And then they start to look at those. I mean, just going back to the pandemic itself, the fact that there were no clear explanation as to why there were disproportionate deaths amongst the black community, for example. There were no clear explanations for that from senior people. And so people then started to come to their own conclusions about why that might be. So you really need to give clear answers and explanations.
Right, and presumably be honest when we don't know the answers, because I think that This pandemic has shown us plenty of cases where there is no conclusion to be had. And Kelly, a final word from you. How do you think the pandemic's affected the groups that you work with overall? Are they emerging into a different world? Are they stronger? Are they, what's their view of the future?
We've got an awful lot of people in general who are suffering with more mental health problems as a result of COVID. OCD, a lot of them are suffering with more anxiety. I don't know, it's obviously it's Ramadan at the moment, so we've been encouraging people just to still stay safe, because obviously we can't stop them from going to see families, and but we're telling them to stay safe. That's all we can. We had a lot of people who were concerned, obviously, when the information come out about the clots. So we've been back again, reiterating all the information we gave them initially, because some of them are saying they're not getting the second injection now. So sometimes it's like 10 steps forward and then a few back again. So I think it's just got to stay on top of things and just keeping the information up to date, current information, and just keeping in touch with the community.
And listening, I suppose, as you mentioned before. We're out of time now. Thank you very, very much for sharing your experience and insights with us today. It's been very, very useful. We'll wrap up. So thanks very much to Dr. Winston Morgan and to Kelly Rostron for joining us. This interview was the first of 3 looking at misinformation and our communities. So we really hope that you will be tuning in for the next 2 in coming weeks and months. Thank you very much, and goodbye.